Norway, melanoma is quite frequent, one of the highest incidences in the world, and also the mortality is quite high. Most of the cases are sporadic, so not hereditary. We have a few, but they are very rare. But we know the families that have familial melanoma, and we follow them closely, and these patients are followed especially close because they have even higher risk than the general population. And these familial melanomas, they are caught much earlier, so they almost never come to our department, luckily. At our department, we get patients with late-stage melanoma, either stage 3 with high risk of recurrence, or even stage 4 with metastatic disease when the cancer has spread. They go to surgery, remove the melanoma, and they also do sentinel node biopsies to see if they have any disease in the lymph nodes. And according to that, they get a stage, and if there's a high stage melanoma, they will get adjuvant treatment, typically immunotherapy, or even some of the patients also get targeted therapy, depending on the genetic profile that they have. I started working in the oncology department around year 2000, and at that time 90% of the patients were dead within a year, even if we tried to treat them with chemotherapy. And this has completely changed now. After 2010, 2015, immunotherapy came in. At least half of the patients do respond to immunotherapy, and the nice thing, if they do respond, they keep on responding. And even if they have a small lesion in the liver or something, even when you stop treatment, it doesn't grow. So we call them long-term survivors. They can go without treatment for 5, 10, 15 years. So it's a complete game changer. But those patients that do not respond well to immunotherapy, or if it's too toxic, we have the option of giving them targeted therapies. But frequently, the duration of the response is shorter than immunotherapy. That's why we often prefer to start with immunotherapy, wishing for the patient to become a long-term survivor. I work in the oncology department. I give immunotherapy, targeted therapy to these patients, and I'm fascinated by the responses. But still, the most important thing is to prevent patients from getting melanoma. So we come in the last line and give expensive treatment, and we can do some good, but the best thing would be to prevent the melanoma from occurring, or early diagnosis, so that we can pick it out, remove it, and the patients do not have the need of any systemic treatment or all the things that we do. That's the most important thing, is if we want to do something about the mortality rate of melanoma.